Assalamu alaikum. Today's our lecture's topic is the endometriosis. So endometriosis is a condition where the functional endometrium is outside the uterine cavity, lining uterine cavity. So by definitions is that endometriosis is a condition in which cells similar to those of the endometrium. The layer of the tissue that normally covers the inside the uterus is grows outside. Most often it is on ovaries, fallopian tubes, tissue around the uterus, ovaries. However, in rare cases it may also occur in other parts of the body. So endometriosis is a medical condition in which functional endometrium that grows outside the uterus or inside the uterus with its sides other than uterus. So if it's going inward from lining endometrium inside the myometrium, then it called the adenomyosis or endometriosis internus. And if outside the uterus, then it called the endometriosis external. Endometriosis with displaced endometrial tissue continue to act as it normally would and proliferate, breaks up and bleeds and each menstrual cycle. So it is the response to the hormones that is bringing change in the endometrium. Because this displaced the tissue has no way to exit your body. It becomes the trapped when endometrium involves the ovaries to form the ovarian cyst that is called the endometrioma. And surrounding tissue can become irritated, eventually develops the scar tissue adhesion, means there is a bleeding, then there is a adhesion formation, fibrosis changes, and then again they cause the deformity of the pelvic viscera. Incidence, it is the about roughly 6 to 10% of women. In some book it is written 5 to 15% in incidence of the women. But it is the variable that which population of the patient. If infertility patient, they means you can see there the higher incidence. While in the other it is the low. So it is the most patient you are seeing or you are examining the patient. It is most common in those in their 30s, 40s, however it can begin as early as 8 years old. During the last couple of decades, the prevalence of endometriosis has been increasing, and this increasing is due to one is reason that they have the you are recognized earlier with they are patients have the awareness, they are reaching, and you have the various groups of the investigation. So by this you can diagnose. The real cause of the increasing incidence is due to delayed marriages, postpone of the first conception, adoption of the small family norms. The apparent one is due to increasing use of the diagnostic laparoscopy as well as heightened awareness of the disease complex amongst the gynecologists. So the risk factors, genetics are the predisposing plays a role. Daughters or the sisters of a woman with endometriosis are at higher risk of developing endometriosis themselves. So if there is a close family members have the disease, so 7% they are the higher risk other than general populations. Low progesterone level may be genetic and may contribute to a hormone imbalance. There is about 6-fold increase in incident women with the affected first degree relative. It has been proposed that endometriosis results from a series of the multiple hits within the target genes in a mechanism similar to developing of cancer. In this case, the initial mutation may be either somatic or heritable. Individual genomic changes have been associated with the endometriosis, including the chain of the chromosome 12, 6, 7, 9, 10, and the 12. Regular physical activity influence that may be linked with a lower level of the estrogen and the reduced endometriosis risk, vice versa. If they have a sedentary life, so they have the bedridden, or they have the less mobility, then they have the more risk. Environmental toxin. Some factors associated with the endometriosis, including not having, they have the nulliparity, They have the prolonged exposure to estrogen, for example, in the late menopause or early menarche, obstruction of the outflow. So the women who have the Mullerian anomalies, they have the vaginal septum, are there the closed, are there the cervix or vagina is closed. So in that case, and the functioning uterus, so their blood comes in the peritoneal cavity, so they form the endometrioma. So this condition is that more common in the nulliparous, these women who are the girls have the Mullerian defects. Signs of the endometrium. Signs of the endometriosis, that if it is endometrium is within the myometrium, that is the adenomyosis or endometrio internal. And the endometriosis externa, where it is the remote areas are in the adjacent to the uterus. So abdominal cavity, it can be occur at any site, but it's usually confined to abdominal structure below the level of the umbilicus. Most commonly ovaries, fallopian tube, cul-de-sac, broad ligaments, uterosacral ligaments, round ligament, rectosegment, colon, vaginal, and the cecum. Because when there's some blood is coming, some are coming through the menstruation, but some blood is going into through fallopian tube in the abdominal cavity. So first from the fallopian tube, they are coming over the ovaries, and after ovaries, blood is some track behind this in the pouch of Douglas, in the cul-de-sac, and the broad ligament. So they form there the is parts of this. So overlying this local area and the round ligaments. The extra abdominal, the common signs are the abdominal scar of the stectomy, cesarean section, pubectomy, myomectomy, umbilicus, episiotomy scar, vagina, cervix, during which maybe this endometrial tissue comes to at these sites and they give response to the hormones. Remote or lung areas, pleura, ureter, kidney, arms, legs, and nasal mucosa. These are maybe goes through the lymphatics or through the blood. So these are the different conditions or different routes where they approach and they give presentations. So this is the endometriosis where the blood comes in the petrocorti. So they form the powder burn or there's a brownish spot. So when these are the actual hemorrhage from which the hemosiderosis formation, macrophagy are atula, then they are the suck. So they become the black, brown, like sulfur burns appearance. Then they form the adhesion fibrosis. So all these fibrosis adhesion they cause. So these are the structures, all that destroy are distorted. So this also powder burn or sulfur burns, like they have appearance this brown color, brown to black or sometimes reddish. Pathogenesis. While the exact cause of the endometriosis remain unknown, many theories have been presented to better understand and explain its development. The pathophysiology of the endometriosis is likely to be multifactorial to involve in the interplay of these several factors. The main theory is that the Sampson's theory, proposed by the John A. Sampson, also known as retrograde menstruation, means retrograde menstruation. Through some blood is coming through the cervix out, but 25% is blood comes into the fallopian tube into the peritoneum. So according to this theory, there's a retrograde flow of the menstrual blood through the uterine tubes during menstruation. The endometrial fragments get implanted in the peritoneal surface of the pelvic organ. Subsequently, cyclic growth and shedding of the endometrium at the ectopic site occur under the influence of the endogenous ovarian hormones. So when there's a menstrual cycle is occurring, these functional endometrium lining give the response. So also there's a lining of the uterine cavity, and also the ectopic site, these cells also give the response. So they are cyclically giving the bleeding, shedding, all this process. So these are going on worse condition. So the endometrial fragments get implanted at the peritoneal surface of the pelvic organ. Subsequently, cyclic growth, shedding of the endometrium at the ectopic site occur. under the influence of the endogenous ovarian hormones. Genetic and the hormone favorable are necessary for successful implantation and the growth of the fragment endometrium. Because some there's a genetic this predisposition, and also there's also some there's response of the local hormone, growth hormone, vascular epidermal growth factor. These are all give the response, and so they are giving the cyclic shedding. And when these are the increasing more, so they cause the fibrosis and the adhesion. This theory explains only pelvic endometriosis. It fails to explain the endometriosis other distant sites. So the other is the Meyer's and Owen's of theory, that is also known as the coelomic metaplasia. Metaplasia is the actual one adult cell is chained to other adult cells. So when there is a chronic irritation of the pelvic peritoneum by the menstrual blood may cause the coelomic metaplasia, which result in the endometriosis. Coelomic cell from which endometrial and the peritoneal cell develop under the metaplasia, abnormal change in the nature of the tissue means one cell type to other cell type. This theory can explain the endometriosis of the abdominal viscera in the rectovaginal septum and the umbilicus, means there is other areas or other organs. Halban's theory, that is also known as the lymphatic theory. When there is when some you have listened that some women have the when they have the menses, there's also blood is coming from the eyes. She have the bloody also. They give also. So this theory is explained that there's a distant they have the endometrial shedding, or sometimes they have this in the other area, lung area or other areas. So it is known may be possible for the normal endometrium to metastasize the pelvic lymph node through the draining lymph nodes channel of the uterus. So the vascular theory, fourth one, that explain the endometriosis at the distant sites at the lungs, and arms, and the thigh. Direct implantation when there is any operation procedure done. So these are the maybe cells come and attach them. So these are the endometrial or residual tissue start to grow at the susceptible individual when they implanted in their new sites. Such sites are the abdominal scar following the hysterectomy, cesarean section, tubectomy, myomectomy. This theory explains endometriosis at the episiotomy scar, vaginal cervicosite, but fails to clarify the endometriosis at the sites other than mentioned. Environmental theory, somatic mutation of the cells due to environmental factors and the pollutants and the toxins. Thus, it certains that not all the cases of endometriosis can be explained by just a single theory. So that is why this disease is called the disease of the theories. The pathogenesis and the pathology is behind this, that the endometrium is in the ectopic site, has gone to potentially to undergo changes under the action of the ovarian hormones by proliferation. Changes are constantly evident. The secretory changes are conspicuously absent in many and may be due to efficiency of the steroid receptors in the ectopic endometrium. Assisted growth and shedding continue till menopause. It periodically sheds and bleeding may be insisted and the cyst becomes tense and the rupture. As the blood is irritated, there is a dense tissue reaction surrounding the lesion with fibrosis. If it happens to occur on the pelvic peritoneum, it produces adhesions, puckering of the peritoneum. If insisted, the cyst enlarge with the cyclic bleeding. The serum gets absorbed in between the periods and the content inside the become chocolate color. Hence, it is called the chocolate cyst. The term endometrial cyst or endometrioma is preferred to chocolate cyst. So chocolate was because the blood when this is collected, so it become brownish color. That is why called the chocolate cyst. Naked eye appearance. When you are visualizing the peritoneal cavity, when you are opening the abdomen or through laparoscope visualizing or the laparotomy visualizing. So the features of the pelvic endometriosis, small leg dots called the powder burns seen on the uterosacral ligament, pouch of the Douglas. Fibrosis and the scarring in the peritoneum surrounding implants is also a typical finding. Red flame-shaped areas, red polypidal areas, yellow brown page, white peritoneal areas, sub-ovarian adhesion. In the microscopic, there is the presence of the endometrial tissue, both blades and stroma, adjacent to the lining epithelium. There may be presence of the large polyhedral phagocytic cells laden with the blood pigment hemosulfate. The cyst wall is composed of the fibrosis tissue and compressed ovarian cortex. So the clinical manifestation, how they present the patients. They have a different presentation. Sometimes accidentally you find, sometimes they have a presentation. So different presentation like dysmenorrhea. These are the painful menstruation. Painful menstruation, and there's the disabling cramping pain and the menstrual pain that is get worse at the end of the menstruation. There's a two types of the dysmenorrhea. One is the primary, second is the secondary dysmenorrhea. Primary dysmenorrhea, that is usually occur, that is the start from the menses, before the menses, and when the menses is started, their pain is relieved. But these are the congestive dysmenorrhea or progressive pain that is the worst at the end of the menstruation. And these are the typical feature of the endometriosis. So why these are the end of the menstruation is worsening? Because they have the blood is shedding in the pelvic peritoneum. They give the delayed response. So when this blood is coming in the peritoneal cavity, these are the shedding occur of the pelvic peritoneal endometrial cells. So they cause the bleeding, fibrosis, and this all inflammation, irritation of the pelvic peritoneum. So these are that is why the pain is worsening at the end of the menstruation. But if this is going on the worst condition, severe condition, then they have that throughout the menstrual cycle, the pain is remaining low grade, or sometimes there's a severe type of the pain. The chronic pelvic pain typically accompanied by the lower backache or abdominal pain when there's a severe pain, adhesion, formation, and there's a uterosacral ligament. This uterosacral ligament is containing the nerves. So where the implant of this endometrial tissue, so they cause the pain. And when there's adhesion and the uterus is get adherent to each and all the bladders, so they have the continuous and the backache and the pain. Dyspareunia, they have the deep dyspareunia. One is the superficial dyspareunia and another the deep. Superficial when there is a vulvitis, they have the superficial deep dyspareunia when they have the adhesions in the pelvis that is causing. Dysuria, urinary urgency, frequency, and sometimes painful voiding because of this adhesion formations. So the woman's life is a social life, and they have the working woman have the difficulty in moving, or this her function is disturbed. So endometriosis, they have the severe pain, all these conditions. These are women sometimes present with the abnormal menstruation. Abnormal menstruations, they have endometriosis, menorrhagia, the predominant abnormalities. Menorrhagia is defined as the cyclic bleeding at a normal interval, but the blood loss is excessive. Normally it is the 5 to 80 ml, but here the more than 80 ml. And duration is sometimes there's a more than 7 days. Sometimes both features have, sometimes there's a single, they have the heavy bleeding. Due to congestion, increased surface area, hyperplasia of the endometrium, and there's a menorrhagia in the pelvic endometrium. Sometimes they are the present with, so one feature is the dysmenorrhea, second feature is they have the menstrual irregularity, third feature is the infertility. About a third of the women with infertility have endometriosis. Among women With endometriosis, 40% are the infertile. The pathogenesis of the infertility is depend upon the stage of the disease, at what stage the disease is coming. In the early stage disease, it is hypothesized that the secondary to the inflammatory response that impair the various aspects of the conception. Various. In the later stage, the disease distorted the pelvic anatomy. Addition contribute to impaired fertilization. Other are the diarrhea, constipation, chronic fatigue, nausea, vomiting, headache, low-grade fever, heavy or irregular periods, or hypoglycemia. So the endometriosis symptomatology, heavy irregular periods, and they have the fertility, reduced fertility, dyspareunia, they have the pain in the other part of the body, abdominal pain, and the bowel problems. Sometimes the women have the bowel problems because the adhesion formation, so they have the during defecation, they have also pain. Symptoms are they related to the organ involved, that is a urinary involved, there is a frequency, dysuria, back pain, or hematuria, sigmoid colorectum, then the painful defecation, diarrhea, constipation, rectal bleeding, even melena. Melena means black stool. Sometimes there is the endometriosis inside the lining, so these are the bleeding, so they have the black sticky feces as a result of the internal bleeding. And this will be typical feature. They have the cycling. At the end of the menstruation, they have this black type of the stool. Chronic fatigue, perimenstrual symptoms, bloating, irritability, fatigueness, and the hemoptysis if they have the endometriosis externa in the lungs. So, catamenial chest pain and the surgical scar, cyclic, they have the pain and the bleeding. Diagnosis. Diagnosis is on the one is the first history. History, you have the family history. There's a close relative. They have the 6 to 7% incidence, or they have the she had the early menarche, or she had the nulliparous, and she had the some end of the menstruation, the painful menstruations. All these features, which are the risk factor found in this her history disease, that is found in her history. The detailed family history of endometriosis is a menstrual history. You specify the flow of the blood and the sign of the dysmenorrhea. And the typical of that end of the menstruation, these are the worsening or not. Then investigation for any other sign symptom related to endometriosis. Afterward, the physical examination, abdominal palpation may not reveal any abnormality. A mass may be felt in the lower abdomen arising from the pelvis, enlarged chocolate cyst, tubo-ovarian mass due to endometriotic adhesions. The mass is the tensor and the restricted mobility. Pelvic examination. Bilateral examination may not reveal any pathology. The expected positive findings are the pelvic tenderness, nodules in the pouch of Douglas, nodular feet at the uterosacral ligament, and the bilateral adnexal masses of the varying size. So there is a adhesion formation all around. So the pouch of Douglas is not feeding easily, and they have some blocked or freeze. There's a become the pelvic frozen pelvis. So there's a one reef test through laparoscopy. You pass the posteriorly from the this uterine sound, and you feel the mobility. So there's not seeing this, and there's adhesion formation. So it's showing that how much is the progress of the disease. The speculum examination may reveal the bluish spots in the posterior fornix, and the rectal rectovaginal examination often help to confirm the finding because there's an adhesion formation, and rectal examination you easily see palpate the adenexa and the posterior fornices. So you can better you feel than the digital vaginal examination. So clinical diagnosis testing are there's not definitive diagnosis by these ultrasound or other tests, but you have to with laparoscopy or laparotomy, you have to clear diagnosis. Other are the additional with history examination. You can suspect that these are the most probable condition. The serum marker CA125 test, that is also the tumor marker for the ovarian malignancy, epithelial ovarian tumors. So moderate elevation of the serum CA125 is noticed in patients with severe endometriosis, but it's not clear the diagnosis because it is also positive in the fibroid uterus. It's also present in the pelvic inflammatory diseases, ulcerative colitis, Crohn's disease, where the irritation of the pelvic peritoneum, CA125 level is the higher. Normal cutoff level is the 35 international unit, but in case of the irritative condition, it is remain within hundreds. But if it is more than hundreds, thousands, so it is in the malignant ovarian tumor. So you can suspect the ovarian. But for diagnostic, it is not helpful. But if there is an ovarian endometrioma, so you have to differentiate between the malignant ovarian tumor or this endometriosis. So we CA125 help you that is the malignant or benign condition. Second one, when there is a prognosis of the malignant tumor is required, then we do the CA125. It is significantly raised in the epithelial ovarian carcinoma. These are monocyte chemotactic protein MCT1 level is increased in the peritoneal fluid of women with endometriosis. Ultrasound, it is not much helpful to diagnosis. TVS can detect ovarian endometrioma. TVS and the endorectal ultrasound to found better of the rectosegment endometriosis. And the biopsy confirm the excised lesion is deep. So when you are excise the lesion, then you can see the lining of the endometrial glands where present. The endorectal ultrasound where the probe, one is the probe is using the vagina, in endorectal the probe we use anal through the rectum and the anal area. So it is done to check the cancer of the for uterus. Find the cause of the heavy, prolonged, irregular uterine bleeding and to check whether the lining of the uterus is going through normal menstrual cycle changes. Magnetic resonance imaging technique, it is a diagnostic tool. There is a characteristic of the hypersense intensity on the T1 weight images to the hypotense on the T2 weight image. It is useful for deep infiltrating endometriosis. CT is better compared to ultrasonography in the diagnosis, but in case of the endometriosis, endometrioma are not specific. In case of the when there's an endometrioma found in the ovaries. Laparoscopy, it is a good standard for the detection of the endometriosis. Confirm, it is done by laparoscopy or laparotomy, confirmation of the lesion with the size, shape, site, extent. And the addition of the extent is recorded and biopsy can be taken at the same time. So we can see how much is the disease is advanced, and according to that we have to treat. Diagnostic test, a healthy history and the health history and the physical examination. So we have to take the detailed history, physical examination, visual analog scale. That is the visual analog scale, a numerical rating scale for the best adopted pain. So you have to record the one diagnostic tool, her history. History may you scale how much the severity of the pain and at what time, at what level she had the pain. Because the advanced disease, the pain is not removed. They have the unstanding, moving, she have the worse pain feeling. So scales for the pain measurements in the endometriosis, then vaginal ultrasound with using the vaginal probe, you do the ultrasound scale, laparoscopy, and then immunohistochemistry. Immunohistochemistry has been found to be useful in the diagnosing endometriosis as the stromal cells have a specular surface antigen CD10. Now, the staging of the endometriosis, different factors determine the stage and disorder. The factors including location, where it is the site of the endometriosis implanted, number of the implanted, and the size and the depth. These are the four factors helping the staging of the endometriosis. So location, where is the location means they are the over the fallopian tubes, over the ovaries, and the pelvic peritoneum, rectovaginal septum. And the number, how many spots are present, and how much is the size, 2 centimeter, less than or more than, and the depth of the invasion. So as much as the depth means it's showing the adhesions and the distortion of the, and leading to frozen pelvis. So the surgically endometriosis can be staged first to fourth. So it is the stage by surgical staging. In the ovarian malignancy also we do the surgical staging. So classification of the American Society of the Reproductive Medicine, stage 1. That is the minimal finding is the, stage 1 is also called the minimal, stage 2 mild, stage 3 moderate, and the stage 4 is the severe. So minimal staging 1, that is restricted to only superficial lesion and possibly a few filmy adhesions. Stage 2, mild, some deep lesions are present in the pelvic. Stage 4 is above plus the presence of endometrioma on the ovaries and the more adhesion formation. Severe, these are the above all features with a large endometrioma and the extensive adhesions. Extensive adhesion that is present. So these are the features. Stage 1, you are seeing that the few they have this, but there's not much this adhesion formation occur. Stage 2, there is adhesion formation, and these are the depth is more. While in this case of the stage 3, that's the moderate. There the adhesion formation is also increasing. So these are the lesion over the pelvic peritoneum, rectovaginal septum, ovaries. You can see this in the fallopian tube. And the stage 4 severe, there's a large extension, there's an adhesion formation. So stage 1 minimal endometriosis, stage 1 there is small lesion and wounds and the shallow endometrial implants on the ovary. There may be inflammation around the pelvic cavity. So here the symptomatology, patient is sometimes not much as severe, just they have the painful dysmenorrhea. By the mild disease stage 2, there the light lesions and shallow implants in ovary and the pelvic lining. Stage 3, where the deep implant, the ovary lining, and there the also mass, they have the pain, and their pain is continued throughout the menstruation. Even they have the full of the month. Severe endometriosis, they are the severe stage of the endometriosis involve the deep implants on the pelvic lining. So these are the full adhesion formation. You can see the stage 4 endometrioma. Normally, how is the free? These ovaries are this clear one. They are in the stage 4. How much the deep? They are the adhesion formation. Even you cannot recognize the structure where is the what present. Differential diagnosis, you have to differentiate from the pelvic inflammatory diseases. The patient's description of the pelvic pain during the menstruation, dysuria, dyspareunia are often symptom. So symptom is most likely same because the adhesion formation there also here also. Here is the medical condition which there is an infection of the upper part of the female reproductive systems, and they are including uterus, fallopian tubes, and ovaries, and also inside the pelvis. Different symptoms like the nausea, fever, acute, they have the pain along with malodorous and the vaginal. They have the discharge and the cervical motion, tenderness, adnexal tenderness, typical of the acute PID. PID should be ruled out with a vaginal swab to test for any organisms and that might cause infection, cervical culture, pelvic ulcer. Sonography may show the complex adenosine mass, and they are sometimes they have the tubo-ovarian mass and containing the pus, where the endometrioma contains the chocolate cyst. Ovarian cysts, these are the pelvic pain during menstruation, dyspareunia, dysuria are common symptoms of the ovarian cyst. Ovarian cysts are filled with a clear fluid here, where in the endometrium there is a thick fluid. So they are common, generally have no symptom. When cyst grows large and the multiply, then cause the pain or the problem. Differentiating symptoms may be asymptomatic with an incidental pelvic mass present, the acute rather than chronic pain. To rule out an ovarian cyst, pelvic exam can be performed to palpate the swelling mass on the ovaries. Ultrasound can also be performed to visually verify. So here, there are the free mass. In case of the endometriosis, there is the additions adherent mass. So on the examination, you can recognize. Uterine myoma is a fibroid uterus that is also known the uterine fibra being smooth muscle tumor of the uterus. These are present abnormal uterine bleeding, heavy painful periods, abdominal discomfort. Some of the infertility, dyspareunia are common symptom of the uterine myoma. Sometimes they have the associated feature of the endometriosis with the fibroid uterus. So differentiating symptom, most common symptom is asymptomatic but often present with a heavy irregular menstrual bleeding, pelvic examination, enlarged nodular pelvic mass can be vary in size and the shape. To rule out TVS is done. It shows concentric solid hypoechoic dark mass with endometrium, myometrium. Small myoma may be asymptomatic, but if calcified myoma can be hyperechoic. Calcification will occur, these are the hyperechoic. Adenomyosis. Adenomyosis, that is also called the endometriosis internally. It's a medical condition characterized by abnormal presence of the endometrial tissue within the myometrium. In contrast, when the endometrial tissue is present entirely outside the uterus, so it is called the endometriosis. Symptoms may be identical to those of the endometriosis. They have the severe dysmenorrhea to rule out the. Here, the woman is usually this endometriosis internal adenomyosis occur in the multiparous woman who have the repeated DNC. Here, the uterus is not adhesion locally formed, and the uterus is mildly enlarged. It's the bulky uterus. It is the less than 12 week size, not getting more than 12 week size. So it is the bulky 8 to 10 weeks usually painful menstruation, and the woman is around the 40 years of the age. They have this dysmenorrhea symptom. Typical, these are the symptoms. So you can diagnosis and the treatment of that endometriosis is the hysterectomy. And when you are doing the cut section, you can find the endometrial tissue in the myometrium. To rule out the pre-operative MRI finding, may show diffuse or focal binding of the junctional zone, isolation of the endometrial tissue mass within the myometrium. Histopathological evaluation of the uterus after hysterectomy shows endometrial glands in the myometrium. Laparoscopy may reveal a normal pelvis and the concurrent endometriosis. Preventive treatment. Prevention is always the best policy. So treatment is to avoid the tubal pregnancy. Tubal pregnancy test immediately after the curettage or at the time of the menstruation. Forcible means you have to avoid the curettage, and the forcible pelvic examination should not be done during or shortly after the menstruation. Means at the menstruation time or shortly after, forcible not good. So there's a split of the blood comes from the uterine cavity fallopian tubes in the pelvic cavity. Married women with a family history of the endometriosis are encouraged not to delay the first conception but to complete the family. Curative treatment are to abolish, minimize the symptom, pelvic pain, dyspareunia, to improve the fertility, to prevent the recurrence. Treatment option is the expected management, medical treatment, surgery, and the combined therapy. So these are the treatment options. So they have the early conception you advise, and the option determine the age of the patient, size, extent of the lesion, how much the severity of the condition patient is present, local disease, disorder, fertility, results of the previous therapy. In the case, expected treatment, progressive disease is about 30 to 60% women. Some form of the treatment is often needed to regardless of the clinical profiles to arrest the progress of the disease. So expected treatment, you have to minimal, in case of the selection, that is the minimal disease, with no abdominal finding, no addition formation. There's an unmarried, young married who are ready to start the family, are approaching the menopause. Other is that they have given this, sometimes they give medical treatments. So medical treatment may they have the hormonal therapy. Hormonal therapy, especially the progesterone. So they have found the progesterone, they have the double dual. One is that they are going to atrophy of this endometrium and with the progesterone therapy, and the other way they have been given because of the immunological response to the nature of progestogens. So they also regress this disease. So we can get a better result when they have the can relieve the infertility card and she get the conceptions. So whenever you are giving a medical management, you have to produce two features: pseudo pregnancy or pseudo menopause. So better is the pseudo menopause. If they are pseudo pregnancy state, then you give the estrogen progesterone combination or contraceptive pills. By pseudomenopause, with this atrophy, you bring the changes, and they are which the blood is shed in the peritoneal cavity, so it's going to atrophy and deabsorb. So progesterone, one is another the denazole, that is the we give this from the derivative of the testosterone, another the gastrinone. These are the suppressed steroids and inhibit the growth of the endometriosis, and their use remain limited as they may cause a muscularized side effects such as the excessive hair growth, voice changes, and they also cause the leg cramps. Gonadotropin releasing hormone modulator and aromatase inhibitor. GnRH analog is the best treatment option because they produce the pseudomenopause and all the going to vanish and can we relieve the patient. Another is that GnRH analog treatment is better when there is a minimal disease and you cannot find the diagnosis. Then you give the GnRH analog. The symptoms are relieved. It means that she has the endometriosis. So you can, according to treatment. Sometimes the woman has the hysterectomy, but some ovary tissue is you have done hysterectomy for the endometriosis, and some ovaries are remaining there. So they have the symptoms of the occurring. So at that moment also you can give the GnRH analog. And the women sometimes they have the severe symptoms and they are not relieving a backache or other symptoms. So she wants to have removal of the all the viscera. So before doing her hysterectomy, you give the GnRH analog, and if the symptom relief, then you can give the clearance of the pelvis with this hysterectomy after this test of the GnRH analogs. Non-steroidal, other medical, non-hormonal, non-steroidal anti-inflammatory drugs, that is the like you give ibuprofen, Colston, like severely. They have the symptom relief, helpful to the severe pain, but they have the stomach pain when women who have the peptic ulcer, so you have to be careful. Other the naproxen, sodium, opioids, morphine, sulfate, and the pentoxifylline as the immunomodulate agent and the angiogenesis inhibitors you can give them. If she has the symptom other, that is the she has the symptoms of the menstruation, abnormal heavy menstruation, then you can also give the tranexamic acids and the non-steroidal anti-inflammatory drugs. Surgical treatments have the different treatment options. That is the one is the conservative approach, another is the definitive approach. Conservative approach, endometriosis with severe symptom and response to hormone therapy. So you have to severe or deep infiltrating endometriosis, so correct the distortion of the pelvic anatomy, and the endometriosis are more than 1 centimeter. So conservative surgery is that you have to endometriotic lesion to attempt to improve the symptoms. Here we are doing the endometriotic jump with spots and lesions. You do the electrodiathermy or laser vaporization. With the laparoscopy is the best option. So here the fertility is also improved. And if there's an addition is there, then you do the adenolysis so you can improve her fertility. The conservative other surgical treatment is if endometrioma, you remove that endometrioma. Hysterectomy removal can be used to endometriosis women who do not wish to conceive. For women with extreme pain, perisacral neurectomy may be very performed when there's a nurse to the uterus or cut the. However, this technique is almost never used due to high incidence of associated complication. Pre-sacral hematoma, irreversible problem with the urination, constipations, treatment of fertility. So the surgery is a more effective than medical intervention for the additions infertility associated. So endometriosis surgery attempt to remove the endometrial tissue and preserve the ovaries without damaging normal tissue. In vitro fertilization procedure are effective in improving fertility in many women with endometriosis during fertility treatment. So we have to do the analogs pre-treatment with the GnRH agonist. There's a high chance of resulting in pregnancy and women with endometriosis compared to the short pre-treatments. So when you are doing another is the UNA, laparoscopic uterosacral nerve fulguration or ablation. So where they are with the laparoscope, you are doing there's a crater formation. You burn the 2 to 3 areas of the uterosacral ligament, so they are lessen the pain or this condition. That is called a UNA, laparoscopic assisted uterosacral nerve ablations. The complications are the internal scarring, adhesion, pelvic cyst, chocolate cyst, ovaries, chocolate cyst of ovaries, rupture cyst, bowel ureter obstruction resulting from the pelvic adhesions. Endometriosis associated infertility can be related to scar formation and the anatomical distortion kinking of the fallopian tubes. Ovarian endometriosis may be complicated pregnancy by decidualization, abscess, and rupture. Thoracic endometriosis is associated with recurrent pneumothorax at times of the menstrual period, termed catamenial pneumothorax. So, chronic pain related to endometrial pelvic implants, anxiety related to effects of the endometriosis and fertility, deficit knowledge related to diagnosis, treatment option, and ineffective sexuality patterns related to manifestation of the endometriosis. Now the question answer session. Any question? You hear me? Students, you hear me? Any question? क्या ठीक है? जी बेटा. Any question?
Ma'am, what is the cause of endometriosis?
Cause is exact is not known, but it is the genetic predisposition, local environmental factors, and there is sometimes the Mullerian anomalies, like they have the cervical osseous growth of blood bear growth, so it's going into peritocopy. So exact cause is known. Different theories, that is I told you, these are the reasons. You understand? Got my point?
Yes, ma'am.
Yes. Okay. Any question? Any question?
No, ma'am.
Okay. You understand?
Yes, ma'am.
Yes, ma'am.
Okay. Any question?
मैम
Yes.
मैम आपने एक मेडिसिन बताई थी जिसमें आप इसके साइड इफेक्ट ये थे कि
Can you speak loudly? What?
मैम आपने एक मेडिसिन बताई थी एंडोमेट्रोसिस की ट्रीटमेंट के लिए जिसके साइड इफेक्ट्स एक्सेसिव हेयर्स प्रोड्यूस होंगे और उसकी वॉइस डीप हो जाएगी तो
एंडोमेट्रियोसिस की मेडिकल ट्रीटमेंट के साइड इफेक्ट्स, मेरा मेडिकल ट्रीटमेंट जो है उसके साइड इफेक्ट अकॉर्डिंग टू दैट कि अगर denazole, usually we are using the denazole, that is the testosterone derivative. So there is some hirsutism, there is a deepening of the voice, and leg cramps are severe if you are giving the higher doses. And if the less doses, so less effect. And the non-steroidal anti-inflammatory, there the gastric ulceration, all these fine. GnRH analog, we are giving for the time being. If you are giving the for prolonged period, then there's osteoporosis or other condition can.
तो मैम ये जो मेडिसिन यस मैम ये जो मेडिसिन है इनको अगर वो क्योर हो जाते हैं तो ये हिर्सुटिज्म एंड डीपनिंग ऑफ वॉइस पे सही हो जाएगा बाद में?
बेटा अगर माइल्ड है तो there's a conditions are improved, and if she got the pregnancy, there's a conditions improved. But if it is the moderate or severe condition, it is a very worse condition, so it is not improved. So there's sometimes they are end up in the hysterectomy or this condition, and even after hysterectomy, there's adhesion formation. They have the some pain is remaining there, and the remnant ovarian tissue, if there's present, so because there's a very difficult to remove all the ovaries. So in that case also they have this, sometimes they want also receive the treatment after that GnRH analog, all these things, because of the remnant ovarian disease that is called. So sometimes there's a next time again they have the next surgery is needed for removal of that remnant tissue. You got my point?
Yes, ma'am.
Any question?
No, ma'am.
Okay. अच्छा बोले एक बार फिर